everyone. Thanks so much for being here. I am in the corner, so you can sort of see me on this camera. I'm Allison Benjamin. I go to Creighton University, and I'm on the National Education Committee for SNaHP. We are so excited to welcome Dr. Joseph Jarvis today for this seminar. Dr. Jarvis trained in medicine and public health at the University of Utah, eventually board certifying in family practice, preventative medicine, and occupational and environmental health. He has experience with both federal, OSHA, and state, Nevada, and Colorado health agencies. Dr. Jarvis held faculty appointments at schools of medicine in Utah, Nevada, and Colorado, and has been a public health consultant for 30 years. During a quarter century of outspoken advocacy for single-payer health system reform, Dr. Jarvis has published 2 books and produced a documentary called Healing US, or Healing Us, which can be viewed online. Currently, he chairs the board of directors for Common Sense Healthcare for Utah, a nonprofit organizing to place single-payer health system reform on the Utah ballot in 2026. So welcome, Dr. Jarvis. We're so excited to hear you speak.
Thank you. Thanks. It's an honor. It's an honor to be invited to speak to you, the coming generation in healthcare, about the creation of Medicare for All. It's a political movement, I think, that will require everything that we all have to give. I'm a Medicare beneficiary myself, as is my wife. Between the two of us, we have lots of experience with seeking health care using traditional Medicare with a supplemental plan so that we know what a remarkable and useful plan and program Medicare can still be. However, I haven't been invited to speak to you because I've become old enough to participate in Medicare and know firsthand how efficient and practical public financing of healthcare is. Rather, I've been asked to speak because I have a political perspective which is uncommon, I think, among single-payer supporters. I'm an original conservative, by which I mean I grew up in the tradition of conservatism that was birthed by Abraham Lincoln and U.S. Grant, and then reshaped by Teddy Roosevelt, and last represented in the presidency of the United States by Dwight D. Eisenhower. I was born and raised in Arizona, back when Senator Barry Goldwater was the dominant political force there, and I learned my conservatism from him through my mother. I distinguish original conservatism from that brand of politics now routinely associated with the Republican Party, which, in my opinion, isn't conservative at all. I'm not here to educate you about who is and who is not a conservative, but I make this point of distinction only to show that original conservatives honored and revered the necessity of government intervention in the lives of constituents. Lincoln used the federal government to preserve the Union and emancipate the enslaved. Grant created a new branch of the federal government, the Department of Justice, in his efforts to establish a just way of life for newly freed African Americans. Teddy Roosevelt, who was both an original conservative and the original American progressive, used the power of the federal government to give the average working man and woman a square deal, meaning a chance to use his or her labor to make a life for a family. Eisenhower made interstate automobile travel more rapid and available to all. They all believed that the government is an honored institution with a mandate to serve the people. Goldwater likewise felt that government was honored, but he clarified that conservatives are apt to argue about which functions of government should be reserved for the states and which were better left to the national government. I'm still persuaded by Goldwater's 10th Amendment ideas. But today's so-called conservatives do not honor the role of government in our lives. Beginning with President Reagan, it has become common among these reactionaries to denigrate government, run for office promising to throttle it or eliminate it, and justify all that by saying government is not the solution to problems because government is the problem. These present-day government nihilists are not conservative. They are merely market ideologues, mistaking not only the role that government should play, but what the legitimate role for market forces might be. I don't believe these pseudo-conservatives make up a majority of those Americans who align themselves on the moderate or further right side of the political spectrum, but I do acknowledge that they take up a great deal of the oxygen on that side of the room. So why talk about conservatism at all in the setting of a discussion about how to create Medicare for all? Well, for the obvious reason that if we are to defend Medicare, improve it, and extend its benefits to all Americans, we must persuade and enlist more than those Americans who already favor Medicare for all, who are by and large the progressives on today's political spectrum. So how does one persuade moderates and conservatives to think broadly about single payer and ultimately embrace it as a conservative policy and act to influence the body politic to change how we do healthcare business? Before I answer that question, let me advise you all who may be seeking to speak with an audience from the right side of the political spectrum about single payer that the ideologues that are out there are not persuadable. Rather, they have a permanently skewed perspective, and they only seek to confirm their biases about how terrible government is. Don't waste your time and effort positing the ideas that I'm about to describe to someone who is permanently and intentionally blinded by nonsense. Spend your time with those who can make sense out of the facts concerning single-payer health system reform. So here are the three main points that I make repeatedly to my conservative and moderate friends, family, and neighbors in Utah, which is a very conservative place, but also elsewhere when I speak. First, single-payer healthcare is constitutional. Second, single-payer healthcare is the most fiscally conservative method to finance healthcare. And third, single-payer healthcare is morally and ethically conservative. Let's begin with what I mean by single-payer being constitutional. This is actually a common sticking point for conservatives. Most of my friends and neighbors in Utah have heard the oft-repeated single-payer advocacy catchphrase, quote, "Healthcare is a human right," end quote. I've been part of the single-payer movement for 30 years, and I've grown accustomed to that phrase, and I believe I know its origins and what is meant by it. I agree that every human being should receive all healthcare that is medically necessary. But conservatives who are not ingrained into the single-payer movement will tend to react as did Surgeon General C. Everett Koop, who I heard state once that no one has a right to healthcare because that right is not articulated in our Constitution or its amendments. Conservative people who resist the notion that people have a right to the care that they need, at least in some respect, are implying that single-payer healthcare is not constitutional, and therefore they will oppose it. When I meet this kind of resistance, which is unfortunately not uncommon, I respond by stating that there is no constitutional right to asphalt either. Yet, beginning with President Eisenhower, governments at all levels in the US have used eminent domain and taxing authority to apply asphalt to public roadways, such that now I can drive from my house to the White House without paying tolls. We do this, of course, because roadways are infrastructure needed by families in the 21st century. Our economy thrives and provides opportunity for all of us to pursue life, liberty, and happiness, in part because we Americans have recognized the need for roadway infrastructure, and we have met that need, even if no right to asphalt is overtly stated in the Constitution. I complete the analogy by pointing out that, like roadways, healthcare systems are infrastructure that 21st century American families need to pursue a fullness of life and freedom. And it is eminently within the reach of government, established to promote the general welfare, to use its authority to publicly fund healthcare. I elaborate further that single-payer advocates are not inventing a proposal to publicly fund healthcare. Rather, Americans have generously funded healthcare through tax policy at federal, state, and local levels for 75 years. We Americans tax ourselves more for healthcare than do the citizens of any other nation on a per capita basis. Programs like Medicare, which have existed for more than half a century, are clearly constitutional, having stood the test of time. Medicare for all, therefore, would also be constitutional. If, however, the single-payer movement were to break through with enactment of a single-payer program in one or more states by ballot initiative or legislation, that too would be constitutional, given that the 10th Amendment to the Constitution allows that, quote, "the powers not delegated to the United States by the Constitution, nor prohibited by it to the states, are reserved to the states respectively or to the people," end quote. Single-payer health care reform is constitutional. Point number two, Conservatives care about reducing the cost of government to its minimum. So I consistently make the point that single-payer health system financing is the most fiscally sound method for paying for health care that we all need. Most advocates for single-payer health system reform, like yourselves, understand the basics of the economic advantages of single-payer, so I won't belabor this point. Instead, I will read selected passages from the narrative of the economic analysis of the single-payer proposal in Utah, authored by Dr. Gerald Friedman of the University of Massachusetts, in order to illustrate what I believe conservative or moderate listeners might find attractive. By way of clarification, we in Utah have named the proposed single payer for our state Utah Cares. This is an extensive quote from Dr. Friedman. Quote, Utah Cares will finance medical care with substantial savings compared with the existing multi-payer system of public and private insurers. By reducing administrative and other waste, including health insurance company profits and excessive prices for drugs and medical devices, and a form of global budgeting for hospitals, the plan would increase real disposable income for the vast majority of Utah residents. It would simultaneously increase employment by reducing the burden of health insurance on businesses. Some of these savings would be used to extend coverage to the 9% of residents still without insurance under the Affordable Care Act. Other savings would be reinvested in the healthcare system to improve coverage for the growing number with inadequate coverage. We spend more on healthcare in the United States because the price of care is higher in the United States. No other country has performed so badly and developed so much waste in its healthcare finance system. By reducing access to needed care, rising deductibles and copays have increased mortality. With few people covered and soaring deductibles and other forms of cost sharing, the cost of being sick and the cost of receiving health care has increased. Facing high costs, we see in Utah the same pattern seen in the rest of the United States. Increasing mortality where the sick cannot afford to access health care. Simplifying the reimbursement process would save physicians nearly 6 hours a week, equivalent to more than a 10% increase in the available supply of physicians. If healthcare providers, including hospitals, nurses, and physicians, were to spend only as much on administration as do providers in Canada, they would save nearly $9 billion annually on administrative costs. In the current system, nearly 10% of total spending goes to the administration of the insurance system, including private insurance and employer-sponsored self-insured plans. And this does not include the vast cost of administration to the general public. Private insurers spend over 20% of premiums on administrative activities, including redundant bill reviews, medical review programs, and other overhead plus profit. Private insurers also waste resources in other ways. Competition leads them to spend money on advertising and marketing. Spending that cures no illness and provides no health care. Raising the medical loss ratio to the level of traditional Medicare, 98%, would save Utah over $3 billion in 2027. Eliminating the need to identify and administer private insurance plans would save employers over $300 million more. Lowering hospital prices to Medicare rates plus 10% would save over $1 billion in 2027, while providing more funding for smaller and safety net hospitals. The International Federation of Health Plans found that for 8 common drugs, the price in the United States is on average 3 times the average price in Canada, England, or Netherlands. Negotiating directly to buy drugs in bulk, the Veterans Administration provides drugs at half the price paid by other Americans. With a population of over 3 million, Utah is as large as some small European countries, which have much lower drug prices. A single agency negotiating prices for almost 4 million residents should be able to negotiate dramatically lower prices, which would save nearly $1 billion in 2027. That's the end of the quote. So in summary, Dr. Friedman projects that Utah Cares will bend the healthcare cost curve in Utah, dropping the proportion of state GDP spent on healthcare from 17% to 15% in the first year of implementation, with a further drop to 12% after the first decade of operation. No similar shrinking of healthcare costs can be projected for business as usual in Utah healthcare. Simply stated, there is no better pathway to healthcare fiscal responsibility than single-payer health system reform. There will be objections to single-payer from conservatives because it is understood by them to be socialism, which some will say is bad policy in itself and allegedly fails to avail itself of the salient effects of the invisible hand of the market. I take a direct approach to the complaint about single payer being socialism. Socialized medicine is a successful model in the UK and elsewhere, and is characterized by the government owning hospitals and employing health professionals. American single payer advocates, including those of us in Utah, do not propose any such thing. Single payer healthcare reform creates a system characterized by public financing for private healthcare delivery. Americans have been publicly financing healthcare for at least 75 years. Single payer advocates do not propose to change that. Americans apparently prefer private healthcare delivery, which is how healthcare in the US is currently organized. Single payer advocates do not propose to change that either. Therefore, single payer health system reform is not a variation of socialized medicine. It's a continuation of how we've long organized our healthcare system. As to the wonders of market forces in healthcare, the answer to that contention takes us to our final point. Single payer healthcare is morally and ethically conservative. So-called market-oriented healthcare is not morally correct and therefore not conservative. The healing of the sick is a sacred subject. All belief systems I'm aware of encourage people to care for all those who are sick and injured. My understanding of the sacred nature of healing comes from the practices for blessing the sick in my religion, the Church of Jesus Christ of Latter-day Saints, and other Christian churches, such as the Roman Catholic. In both of these churches, the sick can be anointed with consecrated olive oil as a way to call down the blessings of God upon them. As a lay minister in my church, I have many times been asked to offer this blessing, and I am comforted to know that for members of the Catholic Church, a similar ministration is arranged. That God cares for the sick is evident from the texts of the Bible. Healing of the sick was practiced by the ancient prophets Elijah and Elisha. The Lord himself healed King Hezekiah. Ezekiel found that the failure to care for the sick was a direct cause of the demise of the kingdom of Judah. He said, speaking to the governing elites of Judah, who had so obviously failed in their stewardship, quote, "Ah, you shepherds of Israel who have been feeding yourselves. Should not shepherds feed the sheep? You eat the fat, you clothe yourselves with the wool, you slaughter the fatlings, but you do not feed the sheep. You have not strengthened the weak, you have not healed the sick, you have not bound up the injured, but with force and harshness you have ruled them." Jeremiah, another prophet, also warned about the societal effects of abandoning the sick. During his 40-year ministry leading up to the destruction of Jerusalem by the Babylonian armies, he preached about the deceit and dishonesty of ignoring illness and injury. Quote, "For the hurt of my poor people I am hurt. I mourn, and dismay has taken hold of me. Is there no balm in Gilead? Is there no physician there? Why then has the health of my poor people not been restored?" End quote. Care of the sick and injured was the signature gift of the man known as Jesus of Nazareth. For instance, in the book of Matthew, we find these verses. "Then Jesus went about all the cities and villages, teaching in their synagogues and proclaiming the good news of the kingdom and curing every disease and every sickness." Matthew 9:35. Great crowds came to him, bringing them with them the lame, the maimed, the blind, the mute, and many others. They put them at his feet and he cured them. Matthew chapter 15, verse 30. "Then the king will say to those at his right hand, 'Come, you that are blessed by my Father, inherit the kingdom prepared for you from the foundation of the world. For I was sick, and you took care of me.' Then the righteous will answer him, 'Lord, when was it that we saw you sick and visited you?' And the king will answer them, 'Truly, I tell you, just as you did it to one of the least of these, who are members of my family, you did it to me." End quote. Matthew chapter 25, verses 31 to 46. That business practices of healthcare can disrupt the sacred responsibility we all have to the sick and the injured is illustrated by the contrast between a 16th century London physician and his stepson. Dr. John Seminges was one of London's most successful physicians in the late 16th century. His mantra for his medical practice was simple, quote, "Before you meddle with a patient, make your bargain wisely now he is in pain," end quote. Quite simply, he urged fledgling doctors to settle the fee for treatment while the patient was unable to really negotiate. Dr. Semingis would be entirely forgotten to us now, and deservedly so, but for the accident of history that by marriage he became the stepfather of John Donne, one of England's greatest poets. Once, while too ill to arise from bed, Donne, then the dean of St. Paul's Cathedral, heard the church bell tolling and wrote his 17th meditation, from which I now quote. Perchance he for whom this bell tolls may be so ill as that he knows not it tolls for him. And perchance I may think myself so much better than I am, as that they who are about me and see my state may have caused it to toll for me, and I know not that. The bell doth toll for him that thinks it doth. No man is an island entire of itself. Every man is a piece of the continent, a part of the main. If a clod be washed away by the sea, Europe is the less, as well as if a promontory were, as well as if a manor of thy friends or of thy own were. Every man's death diminishes me because I am involved in mankind, and therefore never send to know for whom the bell tolls. It tolls for thee. Another man may be sick too, and sick to death, and this affliction may lie in his bowels as gold in a mine, and be of no use to him. But this bell that tells me of his affliction digs out and applies that gold to me, if by this consideration of another's danger I take mine own into contemplation, end quote. For Donne, illness in another, no matter how remote our contact, is to be shared, contemplated, and learned from. Wealth generated from the sick comes not as coin, but as shared human experience, for which the observer can be grateful. Donne would have each of us contemplate our personal danger as we make ourselves aware of the afflictions of others. These lessons of 300 years ago need relearning now. Medicine, once again, has been reduced to a business opportunity. In a nation where tens of millions have no financing for basic healthcare services, leading to tens of thousands of preventable deaths annually, our body politic has become paralyzed by a market-oriented health policy. Bells are tolling, yet we pretend we are not diminished by the suffering of our fellow countrymen. We pretend that the afflictions of the uninsured are not ours to share, as if we individually are an island entire of itself. This despite the fact that we pay twice as much per capita for healthcare than do the citizens of the rest of the developed world, mostly in the form of the highest per person taxes for healthcare in the world. What we are missing is the contemplation of our own danger. Americans are least likely in the developed world to avoid death preventable by clinically appropriate healthcare. We have allowed the business of medicine to so deviate our health system from its principal mission that preventable injury to hospitalized patients has become the third leading cause of death in our country. More than 20 years ago, Tony Snow, who died from colon cancer while serving the Bush White House as press secretary, made this statement, quote, "In the real world, people stampede when somebody slaps up a sign that reads free. That is the theory behind bargain basements, but it also applies to hip replacements and appendectomies," end quote. This is the Dr. Semingis approach to medicine, reiterated in modern parlance, and it makes no more sense now than it did then. I have never met a patient willing to have his appendix removed because a hospital had bargain basement appendectomies for sale. Is medicine a commodity, efficiently traded and distributed by markets? Are patients shoppers or customers, or are they the people for whom the bell tolls? I doubt Mr. Snow actually behaved this way when he was a patient. As far as I know, Mr. Snow did not attempt to start his course of chemotherapy before he had cancer because he found the drugs on sale somewhere. After colon cancer, would he still maintain that Dr. Semingis' approach to making the bargain with the patient while he is yet in pain is the correct one? I don't think so. The Wall Street Journal, an authority on markets and customers, may help us with some answers. A few years ago, an opinion piece in the journal included this thought, quote, research at Dartmouth Medical School suggests that if everyone in America went to the Mayo Clinic, our annual healthcare bill would be 25% lower, about $500 billion. And the average quality of care would improve. Of course, not everyone can get treatment at Mayo. But why are these examples of efficient, high-quality care not being replicated all across the country? The answer is that high-quality, low-cost care is not financially rewarding. Indeed, the opposite is true. Hospitals and doctors can make more money providing inefficient, mediocre care, end quote. If that statement, that hospitals and doctors are paid to deliver inefficient, mediocre care confuses you, let me illustrate with data from a hospital in central Utah. In the mid-1990s, a family physician practicing at SNaHP Community Hospital observed that patients presenting for treatment of pneumonia were not receiving optimal care, and therefore were becoming sicker and dying more often than should have been the case. He organized a protocol for optimal treatment of community-acquired pneumonia. He persuaded every one of his physician colleagues at the hospital to follow the protocol and induced the hospital to adopt it. Almost overnight, the care of pneumonia improved. 25% fewer patients became sick enough to require hospitalization. For those patients admitted to the hospital, the length of stay dropped by 1/3. The length of time before the instigation of proper antibiotic treatment dropped by 1/4. And the cost per case fell by 1/2. This is the optimal outcome in a market. The quality of service goes up and the cost drops by half. In a functioning free market, the provider of such service would be handsomely rewarded. Unfortunately for SNaHP Community Hospital, there was no reward. In fact, the amount paid for pneumonia care fell even more than the per case costs. The hospital took a financial hit for providing better treatment. Hospitals and doctors in our current system get the best payments when they let their patients get as sick as possible. The business model of the medical industrial complex, because of the for-profit motive, is more about making sales than caring for patients. This is what the Wall Street Journal meant when it said there are perverse incentives in the American healthcare system. The fact that American healthcare pays doctors to harm patients through mediocre care is evidence that market principles cannot work in healthcare. A market does not have perverse incentives, and a market commodity does not have a lower price for higher quality. Healthcare is not a commodity. Dr. Seminges was wrong. The best bargains are not driven by the patient's pain. If you want further evidence that healthcare is not a market commodity, consider this. Around 3 trillion of our nation's more than 4 trillion annual health expenditures comes from our taxes. What market is 2/3 tax funded? Why do taxpayers agree to fund healthcare so generously? Because in our hearts and minds, we know that John Donne is right. Any man's death diminishes me. It matters to all of us whether the uninsured tuberculosis patient receives appropriate care. His illness places society at risk. In healthcare, we do not believe in caveat emptor because the buyer is a patient, neither prepared nor able to shop. We place ethical obligations on physicians to serve their patients' need ahead of their own personal interest. John Donne was right when it comes to healthcare. Americans have always known that no man is an island. Single-payer health financing is morally correct and therefore conservative. Market principles do not efficiently distribute or finance the care needed by injured or ill patients. In summary, single-payer health financing is constitutional. For 75 years, we Americans have principally financed healthcare with public dollars. It is well within the constitutional powers of both state and federal government agencies to use those public funds exclusively for first dollar financing of all medically necessary care. Doing so, as opposed to business as usual in American medicine, would make our health system far more fiscally responsible. Single-payer health system reform creates the conditions that allow us to deliver better care, more simply financed to every patient in need, while downsizing the percent of the GDP devoted to our healthcare system. Therefore, single-payer health financing is the most fiscally conservative way to do healthcare business. And finally, single-payer health financing is morally correct. For me and other Christians, it is an answer to the call of Jesus of Nazareth to visit all sick and injured brothers and sisters, even the least of them. It fulfills the mandate of the ancient Jewish prophets for the governing elites to look to the care of all members of society or face the consequences of a weakening society. In fact, all belief systems, as far as I know, from humanism to monotheism, require the devout to practice care of fellow humans. Single-payer health financing concentrates our social interest on the sick and injured and is therefore morally conservative. We in Utah are trying to do something about the bad practices of business as usual in American healthcare. We have organized a 501c4 organization, Common Sense Healthcare for Utah, and are planning to place single-payer health system reform on the ballot in 2026. Our website is commonsensehealthcareutah.org. I hope you'll link to it and learn more about us. I recently spoke in Colorado, where I learned that a single-payer ballot initiative was defeated in 2016. Advocates for single-payer raised $800,000 for the ballot initiative campaign, but they were outspent 10-1 by the opposition. The insurance industry raised and spent $8 million to defeat the measure. So we ask for the help of all people interested in single-payer across the country. Either donate to our cause and help us raise as much as possible to bring our campaign to a successful conclusion, or even better, find a way to place single-payer healthcare before the electorate wherever you live, or before the legislature, hopefully before 2026. That will force the opposition to single-payer to fight on more fronts, and therefore their resources will be diluted. I hope I have helped you understand how to better advocate for single-payer among original conservatives. You can learn more about this in either of my two books about health reform, The Purple World, Healing the Harm in American Healthcare, or For the Hurt of My People, Original Conservatism and Better, Simpler Healthcare. Or you can watch the film Healing Us, which is on Amazon Prime. Thank you very much. I'm happy to take questions.
All right, thank you so much, Dr. Jarvis. What an amazing talk. This is the second time I've heard this talk and it still gives me chills. So such a privilege to get to learn from you. We're gonna start the question period now, everyone. Feel free to turn your camera on so Dr. Jarvis isn't just staring at a bunch of black screens, as interesting as that looks. I'm going to start by reading some of the questions from the RSVPs form. And then you can either raise your hand and ask the question out loud or submit it via chat. So the first question I have is, how do you respond to the individualist argument against paying for someone else's healthcare? Anything you found successful?
Yes, that's a great question because that does come up a lot. For example, people will say, somebody who's smoked a lot, shouldn't they have to pay for their bad habits? And my answer is to basically kind of press back with them. I'm standing in front of them. I'm a large person. I'm obese by any standard that's measured. And I'd say, well, would obesity be one of those things you think that people should have to pay their own health care because they, somehow deserve that? And then I go through the history of how hard I've worked at exercise and diet and how I still remain overweight, and basically encourage them to try to confront that every single person, if I were to interview them enough, as in a family physician sort of way, I could find within their family history or within their social history or their own habit history cause enough to basically argue that they should be on their own. And of course, that eventually divides us as a society into individual units. And that's exactly the weakness that the Old Testament prophets were talking about. When you don't care for each other, you don't have the glue that keeps your society together, and you'll fall apart for reasons that come from the inside, not from the outside. That's for my own LDS community, Church of Jesus Christ of Latter-day Saints community here in Utah. There are specific words in the Book of Mormon that clearly say you cannot reject the needs of people just because you don't think that they've done everything right. That's clearly stated in that book. So I use that scripture as well. But But the basic idea is we're either all in this together or we're going to fall separately because nobody can afford um, the care that they need when push comes to shove.
Great, thank you. Next question is, how do you maintain conservative messaging for Medicare for all despite both parties attacking it?
Yeah, I know. The disappointing thing in my single payer advocacy career was in the Clinton administration when there was both a Democrat majority in the House and the Senate and a Democrat in the White House who had run on health system reform. And our expectations were all raised and we were all excited. The Democrats betrayed us. I've never been a Democrat, so I didn't feel it personally, but I felt the disappointment of the movement, certainly. And of course, that happened again under President Obama. And of course, the Republicans have never even pretended to be right on this. So what do we do when we don't have parties that are actually thinking clearly about this? They are beholden to the biggest lobby and political donation center, which is the medical industrial complex, which I think outweighs in terms of its influence, and because it has so much money, I think it outweighs all other lobbying interests. Well, my answer in Utah is I really have a hard time starting a conversation about Medicare for all because that's a federal approach. And people in Utah are opposed to federal approaches. They like state-based approaches better. One of the favorite things for people who are conservative to talk about is that states are the laboratories of democracy. That came from a Supreme Court document. I mean, it's been decades since that was said. I think it was by Justice Frankfurter. So one of the ways I approach it is by saying this is an issue that crosses political boundaries. It's not politics as usual at all. There are majorities or near majorities in virtually any group that you poll, no matter where they come from and how they align themselves for change in healthcare. There's insecurity in the way we do healthcare business. Everybody in Utah knows that they can't afford the way the system is moving. 86% of Utahns recently said that they are worried that they won't be able to afford care as soon as next year. That being the case, I mean, most of those 86% are going to be Republicans, right? That being the case, it's easy to try to say to them, we're going to do something non-political. We're going to put this out there as a ballot initiative it's not R or D, it's people. It's for the people. It's for the electorate to decide. It's the body politic that will make this decision. That's how I've approached it in Utah.
Great, thank you. The next question is, you explained that hospitals have incentives to let people get sicker as long as efficient care is less profitable. Can you explain more about how single payer would incentivize more efficient or preventative care?
Yeah, I'll take that example from the small community hospital in central Utah as an example. So SNaHP Community Hospital's pneumonia protocol could be replicated in any number of ways for any number of different health problems. If you're trying to approach, for instance, the overuse of cesarean section at the end of pregnancy, you could establish a protocol about how to handle that and how to approach that. You will, if you're the hospital administrator and it's a for-profit hospital, you'll be worried about that because your institution makes more money on C-sections than on normal vaginal deliveries. And it makes more money on sick babies than not so sick babies. So if you remove by providing a single payer provides a different and new way of reimbursing hospitals, and that's through global budgeting. And you basically global budget oriented towards what's better for the patients. So global budget towards the better pneumonia protocol, fewer people in the ICU for that reason, and therefore less expensive outcomes. And likewise for all the numerous dozens and even hundreds of different protocols that could improve the way care is delivered and therefore downsize the actual cost. Your global budget can take all that into account and can provide specific instruction and direction because you're going to be negotiating that on an annual basis. And other hospitals in the state will likewise be negotiating their global budgets. Experimentation will be around different in different parts of the state, and you can share information. Say, this hospital over here learned how to do pneumonia care. Maybe you could implement that at your facility. That's pretty much how it works in a single payer. You improve the quality, and higher quality care costs less.
Thank you. The next question is, can universal healthcare exist independently from the incredibly divisive pro-choice, anti-abortion debate that tends to polarize conservatives and progressives irreparably?
It's a difficult question because, yeah, it's emerged a few times in discussions in Utah, which is that's a sharp-edged social sort of cause that is abortion rights or not, pro-life is hotly discussed in the Utah legislature on occasion. And the way I answer it generally, and it usually gets us past the divisiveness, is I say, what we are going to pay for in Utah will be all medically necessary care. And if I need to, I point out the history of my sister-in-law, who had an ectopic pregnancy while she was away from home and needed to have emergency surgery to save her life, and fortunately was able to get it. That's medically necessary care, life-saving care. And because she was able to get it, she subsequently had another pregnancy that was successfully brought to its conclusion. And I have a nephew who's alive because of that. And the three older siblings of that nephew all had their mother to raise them. They're now all successful adults. So if I have to, that's the story I tell, personal story I tell, and as an illustration of the medically necessary care that's true about reproductive care. And, I'll go into further, debate mode if I have to, but generally that pretty much alleviates the conversation.
Thank you. And the next question is pretty related to what we were just talking about, is who would decide what is medically necessary under this system? You mentioned several times that it would cover medically necessary care, but how would we keep the politics out of that and have it actually be based on best practice guidelines if the companies currently making those calls are possibly not making them?
Yeah, right now, medically necessary is in the hands of the insurance industry, which has a profit motive. And of course, they find a lot of reasons, as many reasons as they can, to not pay for care. The answer to that in a single payer system, the way we're proposing it in Utah, is to list very overtly what are the categories of care that will be covered. These will be very similar to the categories of care that are covered or alleged to be covered under the Affordable Care Act. And I don't have those memorized off the top of my head, but it's primary care and emergency care and surgery, et cetera. So you list those categories, and then you make it clear that there are some things that are not covered because they're not medically necessary. By way of example, surgery, cosmetic surgery is not a medical necessity unless it's rehabilitative cosmetic surgery. But as one example, facelifts, for instance, or tummy tucks are not covered. So we also make sure to tell people that it's the least expensive way of medically proven way, medically necessary way of treating a certain issue. For instance, the cheapest way of treating problems with vision tends to be eyeglasses, not contacts or LASIK surgery. So we will have within the governance of Utah Cares a way of paying for vision care and specifying that there'll be eyeglasses, and we're not going to pay for the fancy eyeglasses, just simple basic eyeglasses. And that then you have to also have a governance process that's open, that's visible to the public, that takes input and has to take input, and it is as far away from the legislature as possible. So we're going to create a commission like the Public Utilities Commission, which has a lot of power in and of itself. 7 members, They will be appointed by the governor and confirmed by the Senate. So there'll be some responsibility to the legislature. That has to be, because that's the constitution of the state of Utah. But they will be independently able to make decisions like this, but with a process that's defined, that's open and subject to public comment. So that's the answer to you. It's volatile. Yeah, it's always going to be. We're going to have to hustle to keep up with medical science as it grows and changes. We'll also want to get rid of things that no longer are viewed as, clinically appropriate. So there'll have to be changes to the benefit list over time.
Thank you for answering that question. The next question is from Anjali, which is, some people against Medicare for All state that it will lead to longer wait times and less effective care. For example, the NHS in the UK and the healthcare system in Canada are commonly thought to have these issues. How do we respond to this?
Yeah, it's the old bugaboo of the queues in Canada. First of all, understand where that bugaboo alleged, where the allegation actually comes from. Most of the information that gets published about that and circulated among conservatives in the United States comes from the Fraser Institute, which is a very right-wing Canadian foundation. It's not based in reality. I'm not suggesting there's no kernel of truth there. Canada does have, for elective procedures particularly, does have wait times. And we need to point out to people as best we can when we're interacting with them that wait times for getting your surgery are a different matter than not being able to get into the emergency room or get to your primary care physician, which is very common in the United States and not at all common in Canada. Yes, there will be always a struggle to try to maintain the budget to support healthcare the way it needs to be supported, although we'll start off with plenty of money compared to any other country. I'm sure we'll end up fighting, having to fight hard for the preservation of our budget. And that's pretty much what's happening in Canada. They probably are on the underfunding side of the issue, and as opposed to us, and we're on the overfunding side of it. The National Health Service in Great Britain is even more sorrowfully lacking in funding due to the poor treatment of the conservative governments that have successfully been in charge in the United Kingdom. And that's how I try to answer it. Look, it's a matter, first of all, of how hard we have to fight in order to maintain the budget for this program that's absolutely necessary for everybody.
Thank you. The next question is from Simon, and he says that for myself and others coming from the left, it'd be helpful to hear which arguments people on the left tend to make that are not particularly persuasive for changing conservatives' minds on single payer. In other words, which issues aren't salient that we're focusing too much attention on instead of what you described.
Well, I have seen more pushback on healthcare as a human right than on any other statement. If I go and make testimony at the Utah legislature, I guarantee you, if somebody during that testimony says healthcare is a human right by way of trying to persuade these very conservative legislators, I guarantee you the response will be, it's not in the Constitution. It's that happens very commonly. And that happens at Congress too. One of the common ways they approach that is they say, if it's a right for someone, then they'll be able to tell me. One of these members of Congress that I've heard speak about this is the ophthalmologist who's in the Senate from the state of Kentucky. What's his name? Senator Paul, right? Rand Paul. He's an ophthalmologist, and he'll say, if it's somebody else's right, then I have no freedom to choose not to provide care to them, and that's wrong. So there'll be that sort of debate, and my preference actually would be for us not to reiterate that. So even though I understand why people are saying that on the left, and I actually embrace it, as I've already talked about, but instead emphasize that there are ways of doing this, that we have been doing these ways for so many years in the United States. We should just continue to fund publicly healthcare like we always have, and deliver it privately. That's what my preference would be, and basically say we're looking for better, simpler care that provides medically necessary care for everyone. That's how I'd argue it.
That makes sense. Thank you for that insight. The next question is from Stephen and Anjali. Says, I was wondering if you have any input on individuals who state that they're worried that doctors will stop providing as much care because they won't be able to make as much money through billing more patients or billing for more services. And Anjali also adds that I have heard some say that doctors will make less money with single payer, so they are against it, especially since we all have massive student debt to pay off.
So our plan in Utah is to raise physician reimbursement, particularly for the Medicaid and Medicare populations, and lower some of the reimbursement rates that go from that generally come from the private sector, from the health insurers who have a higher rate of reimbursement for some things. We're not determining in advance that payment to physicians will be either fee for service or some other method. We want to hear from physicians. We want the governing committee, the commission, to come up with a plan that works for any given sort of sector of healthcare. I give you, for example, those primary care physicians who concentrate on elderly patients with multiple chronic illnesses. That kind of primary care probably is best delivered in a capitated format, where you can, because you have a capitation, you can hire all the various disciplines that you need in the clinic to deal with the multiple problems that these patients present. And they would then be able to do better primary care more efficiently, and the savings you get in reduced hospitalization and use of emergency rooms actually drives that capitation and makes it a very fiscally viable way of approaching it. That may not be the case for high-tech surgeries or other sort of interventions. You need to have the flexibility to try to negotiate that with the physician community. That's the plan. That's what we're planning to do with Utah Cares. I don't know that anesthesiologists will end up, being the wealth generators that they have been historically under Utah Cares. But I know that they'll be paid well enough that there'll be people who will choose to be anesthesiologists. And those people who are motivated by wealth generation as their primary professional interest will probably end up seeking other professions, but that's not because they wouldn't be well paid and well cared for and be able to pay off their debts. I'm hoping that part of this process of generating a whole new way of paying for care in Utah will allow us to reduce the debt that students end up having to incur. That's my hope.
Thank you. Next question is, so who pays for elective procedures under this system? Things like scar revision after burns, things that are life-changing but not medically necessary. Is all costs falling on patients? Do they have additional private coverage, or is there some other option?
Elective, that term does not mean not medically necessary. The gallbladder operation may not be emergent. It may be something that you can schedule electively, for 2 weeks from now or a month from now, but it nonetheless remains medically necessary. So it will be a covered benefit. An appendectomy is typically an urgent facility or an urgent intervention, so that's never elective. But there are a lot of things that are considered elective procedures that they can be scheduled, at the leisure of the system or at the patient, and they may want to take a vacation first and then have their whatever the intervention is. So elective procedures are not ruled out as medically necessary, and they'll be paid for by Utah Cares.
And like scar revision. What about specifically cosmetic stuff and scar revision?
Scar revision would be considered under the category that I mentioned as rehabilitation, use of plastic surgery for rehabilitation. Plastic surgery or cosmetic surgery, I'm referring to the things that people electively do, which really are market commodities. People have all of this, facial surgery, lifts and tummy tucks and all that stuff. That's not paid for now by health insurance, and it's not paid for by Medicare and Medicaid either. And it won't be paid for by Utah Cares. When people want to change their body type or their appearance merely because that's what they want and not because it has anything to do with there having been an injury or some other, for instance, one breast had to be operated on for cancer, and then there's a rehabilitative plastic procedure that will help with the appearance after that. That's included as a medically necessary benefit, but the breast augmentation wouldn't be.
Okay, one follow-up question to that. Would bilateral mastectomies count, or would only one boob count?
Oh, medical necessity. We plan to define that very broadly, and in most cases, we'll believe that physicians have the best interests of the patient when they offer up. We don't have to ride herd on doctors and do a lot of prior authorization under the system. We basically are asking doctors, and most of whom really want to do the right thing for their patients, what does your patient need? And we will fund it. We will pay for it. Now, having one payer gives us a chance to have a bird's eye view, and there will be physicians, I'm sure, that will abuse this privilege. We'll have to come down hard on them. But, we'll try to stay out of people's way. Doctors are going to be inside the arena that is set up as medically necessary care, and we're going to allowed to roam free within that arena. We're not going to try to put a set of reins on every doctor.
Understood, thank you. Last question we're going to end on, from Anjali. I've heard the argument that people do not want the government involved in healthcare. Last year, we watched our legislators in Congress take 15 tries to elect a Speaker of the House. Do we really want them in charge of healthcare? How would you respond to that?
I respond by saying what I've always said, what I've already said to you. This is public funding for healthcare, but the private sector will deliver it. Private sector health delivery is what Americans apparently like. I don't personally have any argument against socialized medicine with government owning and operating the hospitals, but a lot of Americans do. Fine. That's not what we're doing. It's not government healthcare. We are already funding healthcare principally by paying the world's highest taxes for healthcare in the United States. That's how we pay for it. I'm not changing that, and I'm not changing what the private sector does. We're not establishing Utah Cares as a part of the Utah state government. It's a private nonprofit trust fund, which will receive these public funds and shepherd them under the statute that we'll create through the ballot initiative. It's still private sector healthcare.
Great, thank you so much for explaining that. There is one last question, but since it's 8 o'clock, Justin, I can send you Dr. Jarvis's email so you two can discuss it. Thank you so much, Dr. Jarvis, for being here. We've learned so much, and yeah, have a great night, everybody.
Okay, thank you very much for inviting me.
Thank you.
Bye-bye.
All right, actually, I'm gonna stop recording to see what happens.